Good morning. Welcome. My name is Leigh Patterson. I'm one of the speakers this morning, and I'm very excited to welcome you to this session. One of my other colleagues this morning was worried and concerned about our presentation first thing this morning, and I explained to her that anybody who wanted to talk about remediating and failing at 8 a.m. in the morning in Las Vegas was part of our tribe, and it was all going to be fine. So welcome. As I said, my name is Leigh Patterson. I am a former residency director and currently the Associate Dean for Faculty Development and an emergency medicine physician at the Brody School of Medicine at East Carolina University. I am presenting this morning with Dr. Luan Lawson, who was formerly the clerkship director in emergency medicine at our institution at Brody, and is now the Associate Dean for Medical Education. And we are very excited to present with Dr. Michael Kiemeney, who's currently the residency director at the emergency medicine residency at Loma Linda University and is one of our former trainees. We, together and apart, have remediated more folks than we would like to disclose to you this morning. We have no financial disclosures, but personally, I think this is one of the most challenging things that we do. Whether it's going well or whether it's going badly, I think it really takes a toll on us, and we want to talk today about how you do that, and in part about how you're sure you're headed the learner in the correct direction for remediation. And to get started, I'd love to ask, how many folks in here are residents? Are there any residents headed in? Awesome. Anybody here who's a clerkship director? I see several of you guys. Okay. And how about residency directors or APDs? Any of those? Awesome. Awesome. Okay. All right. We're going to talk about remediation. First and foremost, trying to recognize different presentations. This is the tricky part for us. I think sometimes the most tricky part. And we think about remediating learners like we think about the interaction in the emergency department. The single most important thing we try to impart to students who are coming to an M4 rotation or first year interns in residency is, what's your differential? Did you put the right differential together, and are we going to put the patient in the correct lane? So we're going to try to think a lot about recognizing different presentations and talking a little bit about investigating the deficits we believe are there. Look, we'll talk some about resources, and then we're going to talk about outcomes. So we're going to use 4 cases as we go through this today to talk about different types of learners and challenges. Why does this matter to us? I talked a little bit about how much it matters to us individually as the primary educator, but it definitely matters to patient safety and timely care. All of us have learners in rooms without us directly there and in spaces, and they are a reflection of our program, and they are really part of the patient's care experience. It really impacts those around you. It impacts faculty and their workload if you need to remediate a learner in the space while you're caring for patients too. It's an added layer for you. They are not talking about remediating next door. It's okay. I don't know if that's trauma or substance abuse, but they're having fun. All right. It impacts fellow learners, and we all know this is on our survey. You know, is the experience of the learner to my left having a difficult impact on mine? And morale. It is our obligation. This is a challenge for us. Sometimes it is our obligation to successfully, or at least attempt to remediate some of these. Remediating our students and our residents, and sometimes even junior faculty in my current role, we have to think about these folks as adult learners. We cannot approach them the same way we would approach more junior learners, high school and college age learners. And we need to take into account that as adult learners, they are adults in every other area of their life except the educational one, okay? And that has significant impact on it. We'll talk about that in a couple of the cases, but remembering that while you're the intern today really struggling to see patients, or you're the 4th-year student who is struggling to get an H&P together, you're going to go home and be somebody's parent, or you're going to care for an adult, your own adult parent, or you're going to go work a part-time job. So we want to keep some of that in as we think about that together. Adults are self-determining. In the adult education literature, this pans out as adults need to understand why it is you need to learn or do or behave in some different way in order to have that outcome. And I really like, as we think about correcting learners' challenges or helping them move into a new space, to use another concept from adult education, which is a readiness to learn square. So on the side axis, we would evaluate the learner's capability. Is this a learner who has a lot of intellect, who has a lot of fine motor skills? Is this a learner who has a lot of capacity to do this? And then across the top, how complex is what I'm asking the learner to do? Factored into this as well might be those areas of adultness outside of work. If I've got a student, we recently graduated a student who had her 4th child in medical school. Okay, that really affects her capacity on the side. Doesn't matter how complex it is across the top. Her entire medical school career, she worked in the lower half of this square because she had 4 children outside of work, so she had a lot of other burdens in that. We recently had a 4th-year medical student who took over custody of a family member's children. Again, things outside of work, no matter how much your intellectual capacity is, really affects that. If we can put our learners in one of these 4 boxes, we can then think about what are the right resources to put there. So if we have somebody who has high capability and the complexity of the problem in front of them isn't very high, we have opportunities for enrichment. They have growth, they can move beyond. And we forget that quadrant a lot, don't we? We don't take a B+ student to A very well because we've just gotten them over the threshold and we're struggling in the other corners. If we've got somebody who really is struggling, has low capability, low stretch right now, there's not very much elastic, and they have in that bottom right-hand corner a high complexity, high acuity challenge they're facing, that is a learner that needs to be pulled out of the space and have the same approach to their education and their remediation as we would apply to a patient who has complex social situations. Case management would be what we would use in the emergency department when we've got that kind of person, and you need to think about that approach of that pulling out and doing an individual assessment for that learner. So just a concept we like keeping in mind. We talk about learners having difficulty. Recognition that something is wrong is never the problem, okay? Recognizing that something is wrong. Somebody somewhere has recognized something is wrong. For those of you who are the clerkship director or the residency director or the chief resident, it's probably you who recognize something's wrong. But recognizing exactly what's wrong or forming a diagnosis for that is going to require a little bit more attention. You can't plan an intervention until you know what is wrong or unless you're approaching multiple lanes. Again, the same way you, might work up a geriatric patient with abdominal pain. We might be looking at a couple of real potential diagnoses and doing diagnosis and intervention at the same time in our differential. Same thing with our learners, okay? Unless you know the right thing, you're going to need to plan more than one. And then executing it, which we've got resources for. So we're going to take a turn here and walk through a couple of our cases. Dr. Lawson's going to walk us through this first one.
So next is a young woman who comes in, and she's coming multiple.
All right, good morning. I am going to take you and introduce you to Kim. So many of you all have probably met Kim. She comes to rotate with you in the emergency department in January. And people really like her. So you begin looking through her evaluations as you're providing some mid-rotation feedback. And you notice that every faculty member comments really on the fact that the patients adore this person. She's energetic, she's hardworking, she's the person who recognizes that other people need stuff done, and she's offering, can I go to radiology and carry the CT for you? Can I go help? Is there anything, can I carry this other patient something to drink? Extraordinarily helpful. Overall, her presentations are actually pretty organized, but they seem to lack relevant information, or they contain too much information. And she has trouble sort of streamlining and really getting to that EM-focused type of presentation. And when you ask her what her differential is for chest pain, it's cardiac and musculoskeletal, maybe some GERD, but she never really thinks about those life threats in this person who's the 20-year-old who's just gotten back from a long road trip. And she misses some of those obvious things, and her plans are superficial. She puts way too much emphasis on labs. She wants a CBC on everybody, including the sore throat and the viral URI, and can't really seem to explain to you why she wants to get those things. Has anyone met that student? Okay. And you know, in some ways she's not a lot different than the other students, and you're just wondering, is this because she's insecure in the emergency department? She really wants to go into EM. She's interested. Of course, she's been an EMT in her prior life. And as you move through to the end of the clerkship, She's so nice and engaging. You're really interested in trying to help her. And then you find out that she has failed the required exam and that she can't actually pass your clerkship, and so has a limitation on the highest grade she can get for the clerkship. So she comes in to meet with you, and turns out this is her second failed shelf exam. She doesn't really understand why that things aren't going better. She really struggled in the first 2 years, but she says she was successful and did everything. And she was really expecting the third year to be magical for her because she loves patients, she loves team interactions, and she gets good feedback on all her rotations, and yet she consistently struggles. So you begin trying to figure out what is the challenge, how do you go about this? And so depending upon whether your institution is a feed-forward type of place, of which we tend to be a little more open access because we feel like it helps the learner significantly. What we're able to identify are some comments from other rotations and are able to coordinate with student affairs and our promotions and review committee. And we find out that Pete says that she is just enthusiastic, motivated, she builds rapport, seems kind of intimidated, but they are certain that with some more work, she's going to develop a deeper fund of knowledge. You know, it's just early in the third year, right? And then she gets to OB, and she has exceptional interpersonal skills. She gets there early, she stays late, she's compassionate. The patients adore her. They want her by their bedside. And they feel like her knowledge level's on target, and she works really hard to improve it, and she's worked really hard on her differential, and those plans have improved somewhat. So the question is, if we've all seen this student, is there a problem with this student? Do you think there's a problem? Do you think this is okay? Thoughts from the group? Concerned? Anybody concerned? Okay. So we're concerned, really concerned, because she wants to go into emergency medicine, and this is going to become a challenge. And so what additional information do you actually want to be able to help narrow our differential, like as we're thinking about diagnosing her?
Ask her how much she's studying.
Okay, how much? She says she studies all the time. All the time. Other things that you might want to know?
May I ask you a question?
Sure, absolutely.
How did you get the information about her performance in the other clerkships, specifically the comments? Because I'm working in the dean's office as well, and I wouldn't share that with other clerkship directors. So, you know, meeting with the student and asking the appropriate questions, I can understand.
So when we have students who are in trouble, we actually carry all of those students to our promotion and review committee, and we share their transcript and their comments. This is not a process that we did 7 years ago, but what we were finding is that we were getting really to the end of the fourth year before finding out that students had trouble. And I think that really depends on who your clerkship directors are, and if you can actually, if you really feel that they're all invested in helping the student achieve the best that they can. But we really have a group of clerkship directors and our student affairs dean, and we have a academic support and counseling office, and we all sit down around the table together and we meet and review those. And we frequently have the students come to us. If we have a student with 2 outstanding shelf exams, they actually get pulled out of rotations in order to remediate, so it's a little bit higher stakes at this point.
Thank you.
So
I'd say that you need to find out if she's got similar problems with the same types of things that she's struggling with, particularly the shelf exams would be the easy thing.
Right.
Standardized testing, you have a problem with that.
right.
If the presentations might be new to her, but then if it's never been a problem, then you got to find out what changed in between.
Okay. So, and then what's your differential for her? Do you have thoughts as to what's going on? Ideas?
For the study, it would be significant distraction.
Okay.
For ability to present, that's just going to be a new skill that she just hasn't learned.
Okay. So how she's studying, how much she's studying, the time that she's spending studying. Other ideas? Is she studying the right stuff? She is the person, when you ask her, she brings in the stack of books that she's bought 25 of them for the rotation, but she can't actually, she's jumping from place to place. Other things?
Maybe how she feels with interactions with attending physicians, so
Okay.
she gets any anxiety or feels like there's an intimidation when she's approaching.
Okay. So anxiety, what are other things going on? Did you have another one?
It sounds like she's having trouble integrating information as well,
Okay.
or even following the directions before, wondering how she performed on her OSCEs.
Okay. All right. So all great questions. And so I think this really comes down to when we're working with learners, sometimes it's billboard obvious, right? And we're going to talk about some other things that become billboard obvious. And those are things that elicit patient complaints that are very public. Those are frequently professionalism type of issues. But with these types of students, because they're so endearing to us as people, they frequently slip through until there's major issues. Failures on step exams, failures on higher stakes exams, or you're trying to help them match into emergency medicine and they're not really achieving quite the medical knowledge and the performance aspect that you want. And so then you're really looking for inconsistencies and irregularities. And this is one of those things that we all struggle with because we really want to give the student a pass because they're working so hard and maybe they just didn't really know much about DKA or maybe they've never seen anyone with a PE. And so we tend to let them pass without really documenting our significant concerns. And so they slip under the radar until it's high stakes. And so one of the points of this is to encourage people to really make sure that we're documenting all of these nuances so that we're able to have information for action later. So as we think about this, you all have named a number of things. So this is about looking, directly observing her. What are the specific behaviors that she's doing? What are her learning resources? How is it that she's studying? Can she provide a schedule? What are her interruptions? Having other people within the space actually observe her so you're getting a multimodal type of input. Really talking with the learner. Now this is a challenge because this learner just didn't understand. She worked so hard and couldn't really understand why it was that she was struggling. And she really wanted, and she felt like she was pleasing people. So, you know, a part of this challenge is she probably wasn't actually getting the feedback that she needed in a timely fashion. And, Jay.
I'll say the other thing is she getting, because she is so eager and engaged, she's getting off score for
Right.
It's not, maybe that's going to disconnect that score.
Right. And she tells you she's done okay throughout the rest. That really is a challenge, I think, because some of our students who game the system a little too well, you know, they avoid other things that are learning opportunities within the clinical space in order to study the book. And that is a challenge when we're talking about that discordance between standardized type exams and how they perform clinically. The other thing, and this is a challenge, and I don't know the right answer for this, is how does the family play into this? Does she have a significant sort of external expectations that are being placed on her? But additionally, we are having more and more medical students who have parents who are engaged in their education. And I think most of the time we're like, no, they're an adult, this is an adult space. But sometimes families can actually provide significant history of underlying mental illness if that is a concern. And certainly, FERPA still applies to this, but if the student either gives you permission to talk with them or the family's calling you with saying, I just need you to know the patient's hallucinating and having these psychotic episodes at home, sometimes that can be used to balance that normally sort of barrier or wall there. Those are not issues for this student. So you have to take all of this information and be able to synthesize it. So one of the things that we found when we began really delving into this is this student, she said she did well, okay, not great, but she improved throughout M1 and M2. She's a 4th quartile student. Her doing okay was actually failing biochemistry the first iteration, having to repeat it and only achieving a C. And so she had actually barely squeaked by in most of her courses. And it wasn't entirely clear to us whether she wasn't disclosing that information or if she didn't have insight into the fact that she was performing significantly lower than her peers. She had passed step 1 on the first attempt, but she had barely squeaked by within points. And so then we began to look at additional self-assessments and investigating OSCE exams. So as we are looking at this student had significant medical knowledge gaps, but she also had, probably underlying the vast majority of this, were significant organizational skills. And she could not prioritize. She could not prioritize what she needed to study, what resources to use to study. She did have some additional stressors outside of the classroom related to some family demands that impaired her ability and had her in that sort of low readiness category. So as you're working with a student like this, how would you actually target her remediation? Ideas? Is she your problem?
It sounds like the first thing you want to do is kind of get her the right resources. If she has too many resources that make a lot of medical students not,
Okay.
you know, using the most amount of books helps you learn the most.
Right.
Whereas using a couple specific books.
Sure.
Since it sounds like scores throughout a period of time are an issue, and maybe some learning disabilities are part of it, maybe considering doing psychometric testing.
Absolutely.
See if she has some kind of underlying
Absolutely.
disability.
And that's a great point. So we have a 4th-year medical student who has done okay. I mean, pretty solid performance, not outstanding, probably in the 3rd quartile type of student, just diagnosed with a learning disability that significantly impacts his reading. So it sort of explains some of the mismatch between his clinical astuteness versus his step scores. And so thinking about those things, I mean, sometimes we think, well, if you've made it this far, you don't have a learning ability. But some of our students are incredibly intelligent, are able to compensate for that significantly. And so when we think about how to remediate these students, for a lot of things, the student needs to be provided with more feedback. And whether that's on sort of what are the resources that you're going to use, or whether we are going to observe you, whether it's an OSCE or a clinical space, frequently those are things that are the most helpful interventions. Probation is something that I think we pretty rarely do with medical students unless it's a significant professionalism issue. But a number of our students do have underlying anxiety disorders that, or attention disorders that really impact their ability to be able to deal with the multiple stressors. So in undergraduate it was okay, but once there's all of these competing demands and need to multitask, they don't do well. So frequently, too often, I think we put these students on a leave of absence and expect to be able to just start over again and these issues are going to go away. We've really been trying to get away from that because it does not help the learner and they just restart with the same underlying concerns. And then the learning assessments, as you mentioned. The other things that we've engaged with our office for academic counseling are some time management skills and literally having them map out how they spend every minute, when they interrupt for social media, and what are their family demands. For students who specifically struggle with standardized exams, we work with them on an error analysis and actually have people observe them taking exams. How many times do they change their answer? Do they have it right the first time? And actually having them think out loud as to how they answer those questions. Self-assessment, really trying to help our learner be reflected because they are not going to be successful over a lifetime if they can't figure out how to initiate these actions themselves. And then disability. So there are people out there to help you. I think some of the times we feel like it is just us. So thinking about what are your opportunities within your own institution. Promotion and review committees, if they are set up in a student and faculty friendly way, we have really adopted the feed forward information. So all the clerkships directors sit down and see the information. We know what the issues are. We've actually been much more engaged with having students come and talk to us to be able to describe what their insight is, and it really gives us a better idea of what type of concerns we have. focused on learning assessments, utilizing clinical skills, and then and simulation is another great way to have students think out loud through this so that you can help identify where the challenges are. And really what we are looking at is all of our mentoring and coaching should really be thinking about assessing, developing a differential diagnosis, and a treatment plan for these students, complete with deliberate practice, feedback, reflection, and it needs to be ongoing. For most of these students with this issue, it is not something that is going to end at one point in time. So when this student, the student was not competitive for emergency medicine, they did ultimately work very diligently with our academic support office to develop time management plans, ultimately did much better on step 2 than what they had performed on step 1, and successfully matched into what we would call a parallel pathway, but was very successful and happy with their placement. But these are students who frequently as residents need to have some facilitated support as they transition, because for them, if there's an underlying anxiety component, that as they transition to a brand new place can frequently creep up again.
All right, I'd like to shift gears for a minute and talk about our resident case. The second case we'd like to present is that of BB, who at the end of the intern year had scored one of the top scores in the program on the in-service exam, passed step 3 handily with a strong score, but was beginning to be identified as, quote, struggling or not getting it by faculty members. In our PGY 1 through 3 program, at this point in time in the year, we're looking to our interns and assessing that readiness to step into an upper level resident role to manage a larger part of the department. And faculty who had kind of been okay all year were beginning to get antsy about the thought that this person might step into that space. For faculty who had completed evaluations, the feedback was that patient care and decision making was very deliberate and very slow and seemed to progress very sequentially. Faculty described this person as being compassionate and then always seemed to pause after they said that, because this person really liked patients, definitely wanted the best for patients, didn't seem to be warm and interaction in that way. On more objective measures, this person's caring for fewer patients than the peers seems to lack confidence. And then patients and family members, and even some of the nursing staff, described peculiarness in behaviors. Very reliable, showing up on time for all shifts, going in to see patients, but weird recurrently popped up in feedback coming to us about this person. The parents of one young patient who were relatively recent immigrants to the country, when they expressed their concern, said, surely he must be drunk, because he just interacts and moves in that way that they attributed that to it. He was not intoxicated on shift. That was not our issue. Nursing really said he's polite but very rigid, and he takes significantly longer than other learners to do, other residents in the space to perform minor tasks. Major tasks were also a challenge. This person's already lost a wire in a central line once on shift. Senior faculty that had a little more experience really thought the problem was struggling about the chief complaint, that he could really describe in detail underlying science, underlying mechanism. If you told him what the right diagnosis was, he knew everything to do, but somehow the connection between book smarts and the patient in front of him were not happening in the way they began to see it happen in his peers. So as Luan asked, is there a problem with this resident approaching what should be a little more experience? I see some sighing out there. Oh, yes, and a whole lot of nodding. Yes, there's a problem, but what is it? And if we were to answer that question, what would help you better answer what is going on with this person or get to what might be the underlying problem with this learner? What else would you like to know from me about him? Yes.
I have some direct observation because a lot of times you just send people in to go do the H&P and nobody actually really watches that.
Right. We extrapolate from that. And we don't know, did you ask the right questions? Did you listen for the answers? Did you ask the follow-up questions? Did you get everything from them and just not understand it? We don't know. You're right, without direct observation. So we have some direct observation. You had a thought. Had someone seen this before?
See the scores, yes, so that's skills exam. Is there it's pervasive?
Right, so looking at other information, how did other rotations go? Hopefully, what were the recommendation letters from other EM institutions before you came? Yes.
I think that's a great idea, but those are unfortunately little mini snapshots, right? We don't see us in one day, and all some things. So giving the information back to him and saying, hey, here's some observations, here's some metrics about patients per hour, here's things like that. Are these things where you produce slower when you do things outside of your department and like some of that per day is more personalized in some way?
Yes, I see a couple of folks.
Either straight mental health diagnosis or mental health eval.
Mental health evaluation or some other diagnoses, yes.
One thing I wonder is if this person a little off the autism spectrum disorder from what they described.
Sure.
I wonder about a conversation, for some of our residents, it just seems like, and sometimes they have, kind of stumbled into the wrong specialty. You know, there's sort of that type 1 thinking that's intuitive, fast, gestalt, that honestly we're short order folks. We're in the ER, right? I mean, we're not running chefs. And that maybe a different specialty would be better suited if they sort of prefer that type 2 deliberate, logical.
Sure.
Maybe a conversation that maybe they're feeling the same thing, but they want
Right, so let's sit down and maybe perhaps do a little bit of career counseling. So I hear some career counseling, I hear some mental health, some former evaluations. I also heard a little bit of a differential of, is this person stemming from spectrum? Right. Sure. So when we talk about our remediation plan, that all of those things would go into that. What all can we get in here? What can we get currently, and then what can we get from previously? I will tell you what we could get previously was somewhat limited, and while many of us as scientists are very at peace with the idea of sampling, and we sample to get a picture of the whole, we struggle with evaluation as a sample. We struggle with committing to putting down what we see. There is a tremendous amount of that's a separate lecture completely, but I think that played into some of why this information that we saw was seen in this person as a student, but was not necessarily given the weight it deserved until we got to the place where we were considering advancing this person. The plan and the intervention for this case really needs to think about, and really at the time had to think about two separate groups. And as you begin to look at a learner like this, and this learner in particular, then there's a bit of a dichotomy of the program director is the problem. Not me. It's not me. It's you telling me that's the problem. You're not hearing me. You're not seeing me. You're not understanding it. And getting into those directed observations really can help that. I think currently our clinical competency committee makeup and our milestones can help us quite a bit. And this case actually precedes that. We approached it much the same way, but we didn't necessarily have milestones to map it against it. When we look about the intervention, your role as the clerkship director, as the residency director, sometimes as the APD, if that's how you're structured, is to be accountable for the process and keep the process moving forward. That's different than what you need faculty and staff to do, which is to take on each of these roles you're saying. Is there somebody who's going to do directed observation? Is there somebody who's are we going to outsource this to get an OSCE completely outside of our department? Because as some of you mentioned, clinical skills is pass-fail. You know, step 2 CS is pass-fail. We don't get your detailed report. I don't know if it was the note. I don't know if you are marginal on your interactions. But if I can replicate that in my own space. Somebody's got to be the learner's advocate. No matter how this goes, someone's got to sit next to this learner and not be part of the judgment or the accountability or the process. They need an ally in the space, and we attached an ally to this person. And then other people have got to do just basic education, however you assign that into the space. We created a contract for this learner, and if your institution does not require you to do this for remediation, I highly recommend it. We will upload a sample learner contract as a handout attached to this that you can use through the app if you don't already have one. because it really gives you a lot of protection. It helps with accountability for the process and the timeline, and it protects you and the learner both. Currently at our institution, after several of these remediations, we have a proscribed way of using our learner contract and letter that has been reviewed by our GME's HR attorneys. But it should begin with a description of the problem. Which milestones are you not up to evaluation on? Which behaviors are you not meeting our expectation on, and why? And then what resources? So something for the learner to begin that. Steps to the solution. This would again look much like our differential in our plan. What's the plan? What tests are we going to get? What treatments are we going to start, and when are we going to observe to see if any of those take place? All of that's what fits in that contract. I highly recommend that every learner contract that you have for a resident in crisis, and for many of your students in crisis, include outside assessments. Have that learner step completely outside your space. It protects you from that millstone effect that we're judging everybody. And it also gets some perspective on you. I hear a lot of you mentioning what's going on outside. Do we need a mental health assessment? Do we, does this person have other issues in there that might be impacting them? We're doctors, but we're not the learner's doctors, okay? So we can't do that for them if that's where we think it goes. But even when we're looking at educational resources, that outside assessment gives you some real objectivity, and sometimes is that thing that helps a learner hear what it is you've been trying to say. What tasks do you want the learner to accomplish? Be as discreet as you possibly can. I want you to read this section of Tenali over this time period, and I want you to take these exams or this set of questions and score this percentage on it. What are the goalposts? If we are remediating a learner and we think it's going to take 90 to 180 days to do that, we should tell them where we think they ought to be along that continuum. How are we getting some early flag signs? They need the feedback, and we need the flags. Be very, very specific about a timeline. Very, very specific about a timeline and the consequences for not performance. Depending on where you are, and we'll look a little bit later on in this case, depending on where you are in the remediation process, you may or may not consider whether or not you're going to terminate the patient. Terminate the learner. As I said, the execution should begin with the written, and then the timeline, but goals. I expect all of these milestones, I expect you to move from a 1.5 to a 2.5 in 6 months. On a cumulative assessment of milestones 1, 2, and 7. That kind of measurable goals. When you talk about resolution, and we said we might talk about terminating them, you want to put in the final, accomplishing all of these, you will return on track with your classmates at point X in time. If you are making progress, but you have not gotten to point X, then we're going to continue your remediation in this space. If you decide at any point in time during this that you wish to have a career consultation and decide to switch over that, we'll talk about that. Or if you do not meet this at this point in time, then we will terminate you. Again, follow with what your institution has, because some of your institutions will have really gotten into this and have every program doing it the same way, using the same language, hitting that probation with potential for termination at a finite point. But think about all of those. So let me tell you a little bit about what happened with this learner. We created a very detailed learning contract with timelines and began to remediate for 3 months. We did outside consultations. We did not access our Physicians Help Program, which in our state is a great resource for mental health and substance abuse and social issues. We didn't access that because discussions outside, this person had no observable concerns for substance abuse and really had a very stable and non-stressful personal life at home outside this space. We put them in our simulation center to do observe simulations of patient encounters and procedural encounters before he was allowed to return to do procedures. We did a 10-station OSCE. And then we had faculty doing direct observations and a senior faculty member assigned as the guide, the learner advocate. We accomplished about 3/4 of what we expected to accomplish, so he was returned to his space after the first remediation, and within 30 days began to have additional issues. We attempted to do some career consultation because it was very apparent to many of us that he had picked the wrong specialty. This person is incredibly intelligent, incredibly accomplished. My personal thought was this might actually have been a brilliant forensic pathologist, and this was not the right field for him. I really think he would have been very successful at that. He was unwilling to hear that, and we began to receive complaints very quickly after coming off remediation that interactions were odd, peculiar. We're a mixed hospital, so we have privates as well as university physicians, and we got complaints from 3 privates on an ICU rotation of this person can't talk to my patients and can't talk to me. And we had to pull him from this and have a discussion and put on a second remediation that did not go very well, really actually began to degenerate further, and elected not to renew his contract. We were unsuccessful in getting him to consider other specialties, and he returned back to his home state and started over somewhat reluctantly. So it was not our best. I think it was a well-executed remediation, but it didn't have the outcome we hoped it would have. I want to talk now about a learner who we encountered as a student and then in our own residency program who had a different experience with remediation. This fourth-year medical student rotated with us, had an average fund of knowledge and average scores, B across the board, performed clinically slightly above average. The residents really, really liked her. Approachable, easygoing, teamwork sort of person in there with you, laughs, warm, and she matched to our residency program. When she started in July, faculty thought, you know, her medical knowledge is not as strong. She doesn't seem to know the answers all the time. I seem to take her off guard when I ask her a question during the presentation, and she seems a little scattered from time to time. Variations between days. Some days seem to be great. Other days seem to be somebody who couldn't find her pen. She was, again, enthusiastic, and residents really liked her. Faculty had some concerns, and the ones that we could capture first at the end of that first year really did have to do around medical knowledge. We could really see medical knowledge has slipped. This person's not performing where they need to be on track with the others. And faculty commented that she seemed to really struggle with procedural skills and had a fine resting tremor. I'm very anxious about that. So do we have a problem? It's not a good day. That's not the top. So yes, we definitely had a problem. What else do you want to know about this learner now that we're again into that end of that intern year?
I want to make sure see if everything's been stable for her outside of outside of work. It seems like she was average or maybe a little bit better. It mostly seems like as an intern, and then is she now developing some psychiatric issue like anxiety, or has the transition from the intern year to or from fourth year to intern year just unmasked something that was kind of simmering in the background the entire time? So see how is the rest of her life affected, and make sure there's not something else going on that could also cause that issue.
Right. So what else outside is impacting that? Anything anyone else wants to know? Yes.
Seems like somebody that you might be able to just say, some of the faculty have noticed this, what's your perception of it, and then kind of work from there. Because if they've got some insight and say, yeah, I'm a little nervous about having a little more responsibility or whatever it might be.
Sure.
If she's got good personal interactions, you might be able to approach her directly and just see what's up with her.
Sure.
Her perception.
So a directed conversation. What's going on outside? Where are you? Faculty have noticed this. Anything else anybody wants to get? Yes, sir.
Sometimes peers have a bit of indication of something, so like maybe go to the chiefs and say, hey, you're hanging, so-and-so is the intern class, and she came into a relationship with the class.
Yeah.
So sometimes things will come up in that conversation.
Where the peers are. Anybody have a thought or stab as to what a differential might be for this learner with this information, or do you need more?
I think substance abuse is non-differential, resting tremor, and something you have to consider it.
Yeah.
17, I've seen this learner, I've seen people who simply started out in strong out of the gate and not really have to put on the test, and as their peers excel,
Right, right. What would your goal be for this person? I'll tell you, my goal at the time was, how can we get you to catch up to them? They are leaving you. They haven't left you, but they're leaving you. How can we get you to catch up to them quickly? And we began the process of remediation, much like you look right here, on that left-hand side with informal discussions, as you were talking about. And this really walks across the continuum of what I was mentioning earlier, how could you stepwise intervene? We stepwise intervened with some more informal processes. You are falling behind. It looks to me, in evaluating your in-service scores, that you're falling behind in these 3 content areas. Here's what I want you to read. Here's what I want you to do. If you think this tremor is new, let's get you to a doctor and have that conversation, and let me let you know where you need to be. 3 months later, she had shared with me that she had gone to see her doctor and she had hyperthyroidism, started medication. But yet we were still falling behind. And then that became more progressive, and then we began to see changes splitting in the day. Some days were good, some days were very bad. And we had someone who was falling behind on off-service rotations as well. Those evaluations came back. So we started the more formal remediation process, included a host of outside interventions, and at some point during that remediation process, a colleague came to us, a resident colleague came to us and said, I'm really worried. Every time I go over to her house, there are bottles everywhere. Everywhere. They're overflowing her garbage can, and I'm scared she might be driving drunk. So we included a referral in that probation process. We really had progressed, honestly, to a point where we thought we were going to terminate this person because we had sent her to our in-house mental health for all of our hospital employees and said, nope, you're fine, come back to work. It's just the thyroid disease, everything's going to be okay. When we referred her to to an outside evaluation, I got the call, I think your resident has a problem with alcohol. I think it's going to be fine. I got the second call after the labs came back to say, this person was intoxicated while they had a conversation with me with a blood alcohol level probably over 250, and I didn't realize that we have a real problem. Pull her from the rotation right now. And I pulled her, and we sent her to rehab within 48 hours. And she ultimately, after doing quite well in rehab, said, I don't think I belong with you. I'm not sure emergency medicine's good for me, and I want to be a family physician. And has really successfully turned her career around in that space. We almost did not get to substance abuse as her real underlying diagnosis because we got lost along the way and we didn't early on require an outside assessment. Just as a word of advice, in-house resources that are not geared for physicians specifically will not elicit substance abuse correctly. We're all far too intelligent, far too educated, and we're going to game that system. We have to work with specialty providers for that. So we no longer refer anybody to our in-house mental health resources. We refer them all outside. To resources specifically geared to providers. Alcohol, this is a slightly older slide, but thankfully alcohol is still our most common substance abuse. Yes?
I just have a question about that. So, do you think it sort of clear terms in their
Yes.
mediation? Because
Yes.
obviously they might say, well, I feel like I'm being coerced.
So what we do is, yes, so it's a requirement of participation, and you can legally require them to do that. So we require that they self-refer to the resources that the state, to an external resource within 72 hours. We do not require that resource, that they, with that resource, sign disclosures about how much I can receive. But once they have gone to that resource can tell me whether or not that the learner can come back to the program, that they can work, if they do return to work, what return to work looks like, whether or not they have. So we have quite a lot of clout there. We require that they self-refer, and if they do not self-refer, we refer them, and that is, and it's, they have not met a condition of the remediation. We wouldn't necessarily fire you for that, but if you don't self-refer, we would say that's a problem, we would refer you, and then if you still don't go, then we would terminate you for that.
You won't get in legal trouble if
No. No, you're not sending them for therapy. You are sending them for an outside assessment. Our state prefers self-referrals for that resource. That is their ideal, is that you begin with a self-referral process, but they will take they will take referrals directly. Yeah. Sorry. One last point about that. It was really a resident that helped us tip over into that space. It was a co-learner that did that who was really pretty conflicted for months about coming to talk to us about that space. So I think your suggestion and your pickup on that is really helpful. What are your chief residents seeing? Because the residents probably saw this months and months before we did. So, all right. Yes.
Was that alcohol issue present while they were in medical school?
Yes, it was. So the question was the alcohol issue present in medical school? This person, her mother died of alcoholism. She had begun drinking in medical school heavily. It had continued through. Likely in hindsight, the days that were really bad for her in our department are likely days she hadn't drunk before coming to work, although we don't know that for sure in that space. And I think you were the one of you mentioned sort of that unmasking in the intern year. This is most commonly coming up in the intern year. You really are not going to encounter somebody who has all of a sudden begun to develop a problem with that. It is the stressors of the intern year have really pushed them past their leverage point. And you're going to see it in that space. So.
All right. One last case. I know we're running short on time, so we'll kind of go quick. It's interview season, and you're interviewing this medical student who's pretty solid. Third quartile in the class, pretty much right on the average USMLE scores. Has done a little bit of extracurricular stuff, been on the LCME committee, and letters of recommendation are solid clinical skills. Professionalism is fine, not an issue. You liked him a lot, ranked him highly. He chose to stay at his home program, and then as things happened, program director changed during the first year, and the now resident decides to reapply. So you liked him the first time. You bring him in again the next time for an interview the following year. And again, you like him a lot. Kind of believable reason for changing programs. The new director maybe not letting him participate in his extracurricular stuff. He really kind of got involved with the AAMC and even has some good letters of recommendation. So really kind of engaging, charismatic person that has some extracurricular passions and really can kind of add some things to the program. Even has a year-long research position available. So the question is there a problem? Does anything give you pause before putting this person on the rank list? Do you need any more information? What kind of stuff would you need to know?
Are there specific examples that you can get a little more insight on? I just had a problem with the program director doesn't tell you that. But, when the program director told me that I wasn't performing really well, I thought he was full of it. That tells you a little something. So you just got to get just some more examples of specifics.
Right, so letters of recommendation and clinical evaluations didn't really hold anything, but when there's something that's kind of out of the ordinary, out of the usual course for someone's training, you need to dig further. So the thing that was useful for us was really making some phone calls and talking to the folks at his home institution. It turned out for this gentleman, there was some reasons why he wanted to change programs, and it wasn't just because the new program director. He had failed a rotation. He had overslept. He was found down in the bathroom by a chief resident on one of those off-service rotations. He was signing into the EMR when he was not in the building to document patient encounters when he actually was not showing up for rotations. Falsifying procedure logs, and then, of course, had remediated that failed rotation. None of that had made it officially into his transcript or letters of recommendation,
But once you kind of started having some phone calls with the program director there, then some things started to come to light. So this is a case really of professionalism. And some of the most common deficits that you might come across overall in remediation, a fair bit of them can be tracked down to professionalism issues. Looking at it from a slightly different perspective, this survey in West Gem was about a third of remediation cases were involving professionalism, which is always a difficult thing, number one, to track down, and number two, to remediate once you do find it. Who identifies or struggling learners? Most commonly, chief residents, and then again, most commonly, verbal reports from attendings. These kind of things rarely find their way into written evaluations or written feedback, and it's for a lot of reasons. It's you don't want to be the person to submarine an otherwise good, promising career. So people have some reticence to put that in writing. The behavioral standards really for professionalism are not well identified. It's kind of one of those, I'll know it when I see it. And it's hard to put down in writing every kind of unprofessional behavior that could be expected or encountered. And oftentimes it's just kind of lack of familiarity of the grading system or the expectations by the evaluators, and just kind of lack of knowledge on how to write a useful evaluation when there is something that might be a problem, but you're just not really sure. There's a way to put that down without totally torpedoing an otherwise good resident. And then, of course, there's the fear of legal repercussions. Either grievances within GME or outright legal resources. And again, how are residents identified, or how do you find out that a resident is struggling? A lot of it is direct observation or this critical incident. There's this just one thing where it all kind of finally breaks loose. I thought this was interesting. 60%, 3 out of 5 program directors had difficulty having these conversations with residents and convincing them, no, this really is a problem, just because there's not enough written in evaluations or documented to support what they already know is an issue. Do you want to do the summary?
We're struggling right now, even with that 60%, just to get into that space. So, kind of in summary, you're definitely, yes, go ahead. I'm sorry. So, professionalism, a lot of thoughts about that. Professionalism can be difficult to remediate, and you've really got to separate out what's the generational difference in that space, and you must be explicitly clear with the behaviors you wish to see and the behaviors you won't tolerate. I joke in our own program, we have a wonderful attending who is approaching 75. He has said to a resident on one occasion, "That's a very interesting outfit you're wearing to work today." The resident said, "Thank you." That's not what he meant. And he didn't specify it, and he feels like the resident, and he would give feedback to me of, "I don't know that that resident was being very professional today." You didn't tell them. You didn't tell them that. You cannot communicate in cues about that. And so with remediating professional behavior, you've got to be absolutely explicit with that. It's become more apparent to us, perhaps as we're getting older in the space, that that is not an intuitive diagnosis, that it is not that you'll see, you know it when you see it, and surely they're seeing it. And it's no longer appropriate to say we simply model this. You have to tell them exactly what it is they're doing and what they're not doing. And then I would really recommend taped review. If you can put them in the OSCE space, if you have a space where you are able to to video actual clinical encounters and have them review themselves, and then look at others if you can have releases for them to look at others or examples, because it can help them see specifically what that is. You can't approach a remediation on professionalism with the goal that you will make them a better person. That isn't the goal. And you can't link intent with behaviors. It's all about behaviors. It's all about behaviors. You can be extraordinarily professional in our space, interact with all these patients, and not like a single one of them. You do not have to like the patient. You don't have to like the nurse. You don't have to like me as you're attending. That's not a requirement of the job. You have to behave and speak in this X, Y, and Z manner, and you may not do A, B, and C in that. And so I would approach it in that way. I am a big fan with complicated remediations taking place somewhere else and stepping out of the first space that they made the mistake in. I think we have a very supercharged learning environment and a lot of emotion and tension in that space. And if you're going to involve nursing and other support staff in remediating and commenting on professionalism, you should go to a new place. You should find a community rotation, another space, another option so that they can start over fresh in that second space and really walk in with what it is you've given them very clear guidelines about and get a chance to be seen without the baggage from before, particularly if a professionalism blow-up was big. If you had one of these critical incidents where they did something glaring that everybody's heard about through the grapevine, you should consider somewhere else for them to remediate in that. Yeah, it's a great question. It's a challenging one.
Question, Leigh?
Oh, I'm sorry. Yes. Thank you. Yeah, that is a great question. So I'm a struggling student and I don't know how to tell somebody I'm struggling. Absolutely. We have really tried at our institution to make our clerkship directors that safe space to come to for that. We have a separate office of student academic counseling. And if you're at an institution that has that resource, that is a great resource. Our student center, our student and academic counseling center, we even pay a part of the FTE for one of those counselors to work with residents too, to self-identify with that. If you are on a rotation with a chief resident or a senior resident, they are often really, really understanding and warm to be that person to go to. So self-referring to a chief resident is a great approachable part for that. Yeah. A few words of sort of positive encouragement at the end of this. The sooner you find this, the easier it is to fix the problem, or at least to get that learner back on track to be successful in many ways. And I hope we cannot emphasize enough that direct firsthand observation by you, by external resources, is going to be the key to getting that learner laned correctly in the right differential. So. Thank you. I think we're close to all of our time. If there are other questions, we'll be up here at the front and be happy to take those afterwards. Thank you.